So it's great. Thank you for all the speakers. As I said, we're also joined by Zaid Heaton from Mauritius. They were great talks. I think clearly we need to focus on the cascade of care, and that we have great drugs. And I think it's great that we're actually targeting other areas. So Sabine told us that you don't need money to start, but you seem to need an awful lot of money to continue. So I'm going to come back to Sabine on that, but let's start with Zaid. Perhaps you can tell us a little about the program in Mauritius and whether you feel that this is an affordable strategy for Africa as a whole. We've heard about the highlights from various different countries, but for Africa as a whole, where there may be areas which are less willing, are we really going to get the same rates of success?
Well, thank you very much for inviting me to join the forum. So just to put everyone in a little picture, as you know, Mauritius is a small island off the east coast of Africa. We've received a lot of attention, I think, recently because of the oil spill, but also because we were one of the first countries in Africa to essentially to cut down the coronavirus infection. Now, obviously, in relation to another RNA virus, I think the most critical thing in any program is a political will. If the politicians are interested in it, and if they are driven to eliminate hepatitis C, the money will come. Certainly, I don't think there's certainly no program is going to succeed without money being invested into it. It will get cheaper and cheaper as the numbers for number one for the test requirements and number two for medications increase. Then the cost for the treatment per patient will come down, but the overall cost for treatment, I think, is going to cost. But I think the data is very clear that treatment for hepatitis C at an early stage is highly cost effective. But again, it's a question of convincing the politician that this is the right way to go. So to put a little bit in perspective, what we did in Mauritius, like I returned to Mauritius late 2017. And essentially from 2005 to 2018, there was only one hospital in the whole of the island that was treating hepatitis C. And there was around 100 patients treated with initially ribavirin and obviously interferon, and then with Harvoni over this period of time. And then we got into negotiations. So Gilead came forward with an offer for a donation initially for Harvoni, but then they changed the donation, thankfully, to Epclusa. And the first batch of medication came to Mauritius October 2019. And since October 2019 and up to now, we've treated so far 155 patients. And 94 of them have completed treatment, and we have SVR data on 53 of them. So that's kind of SVR 56%. So essentially everyone that has had a second PCR, they were all negative, except for one patient that we were not very sure about compliance. Now the data obviously is not complete for SVR, mainly because of the coronavirus outbreak, but now we're starting to get patients back again, and obviously and getting data back. So we've expanded from one treatment center to 12 treatment centers across the island. And I think one important thing is to make treatment accessible to where patients usually are used to be coming. So we've changed, we haven't made hospitals only the only treatment center. We've also expanded treatment centers to where patients usually get their HIV medications and also where they get their methadone. But to answer to your question, no program is going to succeed without a political will and without funding backing it.
Great, thanks very much. Nicholas, do you want to add on to that, your views?
No, I think that captures very well a lot of the questions around political will and investment. And I think Dr. Sabine's presentation was as well really thoughtful about that. I just think it's really important to think beyond the commodity costs. I mean, they drive basically the cost effectiveness, that is true. But I think, as we heard as well, I think from Dr. Sabine, it is very important to think as well about other program costs, monitoring costs, training of healthcare providers, and integration costs. I think in most countries in the African region, integration such as in HIV and PHC, as we heard, will be the way forward, but there will be additional costs. And I think it would be somewhat dishonest to not really think about those, even though the commodity costs are very important in how cost effectiveness a scaled up program overall becomes.
Great. So, Dr. Sabine, there's a lot of questions coming in, congratulating you on your work in Rwanda, which I think we all share with. But there's a question about what do you do with failures? And I'd like to add on that, what do you do with individuals who become reinfected?
Thank you. And I'm happy to join you and everyone who is watching us, who is following us in this conference. I think with hepatitis C, what we've learned over the past 5 years or more is that it's changing. Things are changing every time. And with data, with information you're getting, not only from the lab, but also from the patients who are telling you, I'm having these effects when I take this medicine, informing us on how we're managing the different cases of patients forward. So initially, the combination of treatment we had has evolved, has changed almost 3 times. And the thing was, how do we change the guidelines in the real time, so that even if you have these new medicine, these better combinations, the pan-genotypes treatment options do not get the obstacle of having these guidelines in place. So we've had patients who resisted to treatment, not as much as we expected actually from the literature, but also we've had patients who get infected, and always the treatment options were captured and considered in our guidelines. Of course, with a cost, with a high cost sometimes, but this is not a loss, but rather an investment. When you go for buying medicine maybe for 10 patients and is costing more than 1,000 patients in the first line. So we believe that with these options in place, when you have resistance, when you have reinfections, and you can be able to manage as per the options we have and the science we have in hand works.
Okay. And there's another question that's come in asking about, do you find any difference in success rates between generics and different types of generics and from, I suppose, Gilead AbbVie produced drugs?
Generally, we haven't seen really a difference in terms of the generics we've used before. I don't know what type of generics is probably referring to, because you need to know actually that generics have different sources. So you need to use the right medicine, trusted, approved. So from the patients we've treated since we started this program almost 5 years ago, we haven't noticed really a significant difference in terms of potency, in terms of success rate, and even side effects. So generics works in the same way as brand new medicine. So we are comfortable with that. We've experienced both, and we see positive results forward.
Okay. Nicholas, how do we're talking about hard to reach groups, often whom are very stigmatized. So how do we reduce the stigmatization of these groups and actually encourage testing?
Yeah, that maybe just on the previous question on the generics, I just want to comment very briefly that I think it is important to support what Dr. Sabine says, and that WHO has pre-qualified several products for different combinations of DAA treatment, and this is quite a rigorous process, and that those different manufacturers have undergone. So they are all recommended for use and have the same outcomes as the originator drugs. On your question, I mean, that is a really difficult question, and I know how this discriminated and sometimes stigmatized the populations are that I mentioned, such as high-risk men or people who use or who inject drugs. I think that we do recommend in different of our guidelines that really enabling environment has to be created, that is as well a little bit about political will, and helps not only with hepatitis C, but would help as well because often those populations have as well increased risk, for example, for HIV, but one has to really make public health approach and not just a justice approach to those populations. So try to decrease stigma, try to decriminalize some of the behaviors that those populations have, and to increase community involvement. Those would be some of the core critical enablers to allow then to reach them and to make them less hidden somehow, and to bring them more into testing, as you said, Dr. Nelson. I wanted to as well say thank you very much for sharing this session and for having me in the presentation. And
no, thank you. Zaid, can I ask you the same question? In Mauritius, is there stigmatization, and what have you done to reduce it for hepatitis C?
Yeah, stigmatization obviously is a big issue, and I think it's both ways. Like patients as well don't want to come forward because they have certain ideas about doctors thinking about them, and obviously the other way as well is the doctors think hepatitis C is essentially a self-inflicted disease, and therefore patients kind of deserve what they've got. So what we've done obviously is that number one, we've educated our healthcare professionals. We've devised posters as well. Essentially to try to limit stigmatization and encourage education about hepatitis C. But I think the most important thing is going to patients, because most patients who have hepatitis C and who are going to transmit the virus are essentially the people who are still using drugs. And these patients are not going to come forward, and certainly they will not attend hospitals. They will attend the methadone centers. They may attend their HIV centers because they are used to the nurses there and they're used to the doctors there. They're certainly not going to attend hospitals because they see the hospitals as a whole kind of different, I suppose, a very kind of, they are afraid to come to hospitals. So what we've done is, number one, we spoke to peer educators. So we have a group of peer educators, and we linked in together with the HIV services for that. And essentially, as I said, to try to go to patients. And number two, we use caravans as well to try to penetrate into the communities, to go and talk to patients. And essentially, we try to limit the number of healthcare professionals going on the caravans. Like, we want as much as peer educators and less healthcare professionals on the caravans, essentially to try to get patients to come forward for treatment. And once you get their trust, then they will come forward to treatment. And essentially, we try to do most of the treatment at the methadone centers, the HIV centers, rather than the hospitals. It's only the complicated patients that have cirrhosis that we detect by APRI scoring. We don't do fibroscan on all of them, but we do detection of cirrhosis by APRI scoring, essentially to try to catch as many patients as possible.
Okay, and do you have experience of point of care testing for hepatitis C RNA? And if so, has it impacted on your management in any way?
Yeah, so point of care testing, we haven't started using it on large scale yet, because we're still essentially, we have a database of patients that we know have hepatitis C, and we are a little bit in the middle of recruiting those patients. So we haven't really gone forward to screen certain populations group and stuff like that to do point of care testing. But certainly we've been linked in with NGOs that have been doing point of care testing, and what we recommend then for all the NGOs that have gone out on their caravans, or during, sometimes the NGOs organize events that people using drugs would come to those events, and they would do their point of care testing in those centers, in those events, and we encourage all those patients who are detected positive to come forward for treatment, either at the methadone centers or the HIV centers, obviously to the hospital if patients want to.
Okay, that's great. Dr. Sabine, last question of this session. there's a question on, treating the hepatitis C patient. You've treated their hepatitis C, but you're still going to have a population with chronic liver disease, portal hypertension, at risk potentially of hepatocellular carcinoma. And how would you manage those, Dr. Sabine?
So I probably missed the last bit of the question, but I think if I recall,
it's really about that if you've cured someone of hepatitis C, what happens about their liver disease, the management of chronic fibrosis, cirrhosis, and their risk. How do you continue them in care even though you've told them you're cured of the hepatitis C?
Sure. This has been one of our challenges at the beginning of treatment for hepatitis C, because most of the patients were found at the late stage of the liver disease progression, and you could cure the virus, but not the damages. And we've had so many liver cancers related to actually undiagnosed, the early stage of diagnosis. But as we treated earlier, as we tested with these campaigns across the country, we've been seeing fewer and fewer cases of patients who are at this stage. And when we had this type of patients who are really needed advanced treatment beyond just DAAs, that's the interest of having integrated programs in existing hospitals at referral systems where further management are needed, including surgery, including even transplantation. So we've had these experiences. I would say the trend has been changing over time, and this explains the importance of early diagnosis and the early treatment to avoid those complications. And that's why the government of Rwanda has initiated testing all who could have this disease and treat before it becomes even costly to manage a few patients with advanced liver diseases.
Great, thank you. I did say that would be the last question, but Nicholas, a last question's come in for you, which I think you can answer briefly if possible. But is there the possibility for the WHO or the Mondial Fund to finance diagnosis, assessments and treatment for those infected with hepatitis C in Africa?
This is a great question. I mean, I'll try to make the answer as short as I can.
Thank you.
WHO is not a funding agency, but the Global Fund, to which is referred here, has actually already an existing possibility of funding hepatitis C testing and treatment in the framework of the HIV co-infection, and it can be included in the country funding requests, and more countries have done it. And I think part of some very early of the Rwandan program has been as well using that mechanism. So it is possible. In the moment, it is limited to the co-infection context. We will see the Global Fund is reviewing their global strategy, what will come in the next strategy.
Great. Thank you all for joining us. We've gone slightly over time, but I think it was very worthwhile. Great talks, great discussion, and thank you all very much for your time.